If other issues, not too surprising, that crashes and traffic citations are associated with unsafe driving. The insurance companies and licensing agencies figured this out a long time ago, and we found data both in aged populations and patients with dementia that these are associated with increased driving risk. In fact, citations and crashes are more important than just having dementia alone in terms of predicting unsafe driving. And if a patient, one study showed if a patient over 70 has 2 or more tickets, they are in the highest risk driving group of any group, including 16-year-old boys who are at the highest risk. Talking about the patient's perception of their driving ability, a lot of times they won't explicitly admit or state that they are having trouble driving, but their behavior reflects it in that they've reduced the mileage that they've driven or in the situations in which they drive. I should say that as people age, they tend to drive less anyway, but patients with dementia definitely reduce their driving more than their age-matched controls, and that this is an independent risk factor for unsafe driving. That could be viewed in different ways. One is that they're not getting as much practice, or that they've recognized that their skills have deteriorated, or that their family has recognized that their skills have deteriorated. So the magic number seems to be 60 miles per week, and less than 60 miles per week is associated with unsafe driving. And obviously those it's hard to really stick to that exact number because people live in different situations, rural versus urban and so forth. But as a guideline, reduced driving mileage is associated with poor performance on driving tests. Also, patients who say that they always avoid driving at night or in the rain, that is associated with unsafe driving. I mean, most of us would prefer, somewhat try to avoid driving at night or in the rain, but if the answer is they always avoid it, or the family says we don't let them drive in the rain anymore or at night, that is a risk factor for unsafe driving. Again, patients who say, I'm fine, I can drive at night, I drive in the rain, I don't avoid that, that doesn't mean that everything is okay. It's only helpful if they report that they've restricted their driving. If they don't report restricted driving, it doesn't help you. We did find some weak evidence that patients with aggressive or impulsive personality characteristics are at higher risk for unsafe driving. This comes to light particularly in certain types of dementia, such as frontotemporal dementia. We looked at neuropsychological testing in terms of identifying unsafe risk, and this is a very complicated area. 2 members of our author panel have published extensively on this, and including one who did a large meta-analysis, and it was not possible to identify a specific neuropsychological test that provided additional prognostic information. I should say that a lot of dementia experts do these tests, particularly tests of visuospatial ability and executive ability, which are not tested very well with kind of the routine screening exams. And a lot of seasoned clinicians believe that they can use this information to identify patients at a higher risk. And we didn't find evidence that it's helpful. It doesn't mean, the cliche is, absence of evidence is not the same as evidence of absence. So they are still potentially helpful, but we just couldn't find anything we could really hang our hat on in terms of evidence. The one test, kind of the standard screening test, is called the Modified MiniMental Status Score. It's a 30-point scale. And there was some weak evidence that patients who score 24 or less are at higher risk for unsafe driving. Again, in the one study, 64% of the people with a score of 24 or less failed, means 36% passed. At what point do you draw the line? That's, we don't attempt to answer that question. We just lay out the data and let people come to their own conclusions. But I think an important thing to say about the modified MiniMental status exam is really not a good screening test, and that scores above 24 are not correlated with driving performance. So in other words, if you give somebody the test and they get 28 out of 30, doesn't mean they're necessarily a safe driver. We looked at compensatory strategies to mitigate risk in patients driving with dementia, things, educational programs, restricted driving, co-pilots, and so forth. And there was one study that had evidence that having in-person license renewal for patients over 85 was some benefit in terms of reducing driving risk. Other than that, we did not find evidence that compensatory strategies were helpful to reduce driving risk. So, in summary, it's a delicate issue. Needs to be handled sensitively, and nothing's in black and white. There's no immediate transition from safe to unsafe. What we can do is look at these data and obtain a qualitative estimate of risk, and then discuss it with the family. And the way this might go about, the way I do it in my office, I mean, the first couple meetings with the patient, again, you're hitting them with a heavy diagnosis, and is just really a lot of shock, and not the time to talk about it. But as things settle down, we can start talking about assisted living and other issues, and driving, and say, you have mild dementia. This is associated with a higher risk of driving. At some point, you're not going to be able to drive anymore. What are your thoughts? And ideally, the family says, no problem, we can take care of it. The patient's fine with it, and if they're eager and willing, and the family's eager and willing, everybody's job's easier. But it's not always that easy. Again, the autonomy is an issue, and a lot of patients don't really have insight into their problem, and they'll deny that there is an issue, and then the family will be in denial, and then we can look at these other risk factors. We have a questionnaire that addresses the risk factors, and we're going to encourage patients and their family members in particular to fill out the questionnaire before they come and see the doctor, because it is a delicate issue, and a lot of times they don't feel comfortable discussing it in front of the patient. But we have this slip, and we can see, okay, been in an accident, the caregiver's concerned, so forth. We think your risk is above and beyond the standard patient with mild dementia, and what are we going to do here? We can look at community resources, make the case with the patient and their family, and see what happens. In some states and provinces, California included, there's mandatory reporting of unsafe driving. I'm from California, that's why I brought up the California thing. But we are mandated to report any condition that may, end quote, affect safe driving. And that's defined as loss of the ability to perform a single function of daily living, which is a pretty low threshold for reporting. I mean, to follow the letter of the law, if somebody is not able to brush their teeth anymore, they have a reportable condition. And it's really a quagmire, a legal quagmire, and the Academy is not in the business of writing parameters to help people navigate through the legal jungle of reporting. So the clinician has to use their judgment, be aware of the state guidelines, and intervene accordingly. In a setting where a patient and the family are not ready to relinquish privileges, or may not necessarily need to relinquish privileges, we recommend doing a follow-up evaluation in 3 to 6 months. I should mention that in this age group, obviously, dementia is not the only thing that people battle with. There are, ocular problems, visual problems, musculoskeletal limitations, medication effects, sleep apnea, strokes, other conditions that can affect safe driving, and that's really beyond the scope of our review, but in considering the whole person, those issues need to be considered as well. In some cases, again, where a patient and the family are kind of sitting on the fence, you can recommend that an occupational therapist administer an on-road driving test, and that there's common sense to that. We did not find evidence that made a difference in terms of outcomes, but again, absence of evidence is not the same as evidence of absence. We're hoping that future research will include high-quality studies. As I mentioned, we looked at about 6,000 abstracts, not that many articles, but of that, about 50 passed muster, which meant there are a lot of studies that are not really useful in a practical sense. And there are standard criteria called the STARD criteria, S-T-A-R-D, and we would hope to see more studies that adhere, or at least attempt to adhere to those criteria so that they will be high-quality studies. We're recommending that studies establish a cutoff point for unsafe driving. Dr. Molnar from Ottawa has made that case pretty successfully, I think. The studies of neuropsychological testing need to control for the presence and severity of dementia, so we can find neuropsychological tests that provide additional information beyond the simple diagnosis. And to have studies reporting in terms of relative risk, it's an easier concept to work with than a correlation coefficient, which is the way a lot of the studies are reported. So that's what I have to say. I welcome questions to elaborate on.
Thank you, Dr. Iverson. Now we can take a few questions from the gallery.